like. Okay, so let's discuss the head and neck. This is the revision of head and neck portion. Okay, so let's use this green color. We are in a scenario that there is 18 years old, painful bulging swelling between mandible and mastoid process, and throbbing pain which radiates to the air. On examination, febrile with tender swelling which is reddish brown in color. Okay, so here the case is that there is a painful bulging swelling. Okay, acute parotiditis, painful bulging swelling is present, and it is present between the mandible and mastoid process. Between mandible and mastoid, and the throbbing pain radiates to air. Okay, the pain is radiating to air. Also, the patient is febrile on examination, and tender swelling which is reddish brown in color. Reddish brown. So for parotid gland inflammation, this is a parotid gland inflammation, and parotiditis is present, and these are the features that there is. Okay, let me search acute parotiditis. Okay. This is the parotid gland and this is the swelling. So what happens in this parotiditis, that there is painful bulging swelling between the mandible and the mastoid process. Between the mandible and the mastoid process, this is between the mandible and the mastoid process. Okay, and it is radiating towards the air. Okay, and the patient is febrile due to the inflammation, and there is throbbing pain, and painful bulging swelling is present. So if this kind of scenario is given, so the diagnosis is acute parotiditis. And what are the causative organisms that cause inflammation of the parotid gland? So these are mumps and Coxsackie virus A, bacterial infection, debilitating disease, myobacterium tuberculosis, and actinomyces. Okay, so the most common are myobacterium tuberculosis and Coxsackie A virus and mumps. Okay, and the bacterial infections, debilitating disease, and actinomyces. The predisposing factors that lead to the infection are the reduction of the flow of saliva. If there is decreased saliva, then following major surgical procedure, if any surgery occur, then this can lead to the infection of parotid gland, enteric fever, and following radiotherapy and obstruction due to the due to duct with retention of secretions. Okay, so anything that can cause inflammations can also cause the acute parotid gland inflammation. But what are the specific things that are leading to the infection in this area? So these are Coxsackie A virus, bacterial infections, myobacterium tuberculosis, actinomyces, and debilitating diseases and mumps. Okay, now the predisposing factors are enteric fever and surgery, and if there is decreased saliva of it, or if there is any ductal obstruction and the retention of secretions occur here, and the following radiotherapy and following major surgical procedures and the reduction of flow of saliva. These are the causes of the these are the predisposing factor of the parotid gland inflammation. Now, how you will treat such type of inflammation? So first of all, you will provide the conservative treatment and the surgical. So in conservative treatment, improve the general condition of the patient, then gives the antibiotics, and soft diet is prescribed. Gentle massage of the gland at regular interval to express the pus, and incision and drainage if conservative treatment fails. Okay, so what kind of antibiotics can we use here? If you want to write the name, acute parotitis antibiotics. Okay, so these are the specific antibiotics, that is ceftriaxone and amoxicillin, ampicillin. Okay, ceftriaxone, ampicillin. You can use these antibiotics. Soft type is prescribed as there is eating difficulty. So, and gentle massage of the gland at regular interval to express the pus. It is a kind of abscess. The treatment is same as that of the abscess treatment, but as it is the gland swelling, so The gentle massage to the gland is given. The general condition of the patient is improved. For example, if fever, then antibiotics are given. If he is in pain, then you can give the analgesics, and for bacterial infections you will give the antibiotics, and the gentle massage of the gland is done. These are the conservative management. Now if these managements fail, then you will provide the surgical management, and these are incision and drainage if conservative treatment fails. Okay, so this was all about the acute parotiditis. There we are having the features of a reddish brown color swelling, and the patient is febrile, and the pain is radiating to the air, and there is painful bulging swelling between the mandible and mastoid. The causative organisms are mumps, Coxsackie virus, and Mycobacterium TB, actinomyces. The predisposing factors are reduction of the flow of saliva, enteric fever, and radiotherapy, obstruction to the duct with the retention of secretions, and these are the treatment options. Now coming towards the next topic, that is pleomorphic adenoma. So we are having a scenario that there is a 50 years old who is having 3 to 3 centimeter painless swelling on the lateral aspect of the neck, just below the right earlobe. The duration of swelling is 2 years and is rapidly increasing in the last 2 months. Painless lump in the right parotid gland, and painless lump in the angle of mandible. The diagnosis, the differential diagnosis, the management, and the complications. Okay, so in pleomorphic adenoma, it was the swelling of the parotid gland. It was between the mastoid and the mandible. Now the pleomorphic adenoma, so we are having a painless swelling, and the parotid gland was painful. Parotiditis, inflammation, so it was painful. Now this is painless swelling, and it is present on the lateral aspect of the neck, just below the right earlobe, and the duration of swelling is for 2 years and it is increasing. So this is pleomorphic adenoma. If it is painless, and if it is having chronic history, then it is pleomorphic adenoma. If it was painful and was acute, then it was parotiditis. Okay, now the pleomorphic adenoma is the most common benign tumor of the parotid gland, and it involves the superficial lobes of the parotid gland. Okay, pleomorphic adenoma is benign tumor, and it involves the superficial lobes of the parotid gland. It is slow growing swelling over the angle of mandible from many years and raised air lobule. It is painless, and the facial nerve is not involved, and swelling cannot be moved over the zygomatic bone. These are the clinical features. You can identify it from the following features. That is, it is the most common benign tumor of the parotid gland, pleomorphic adenoma. What is pleomorphic adenoma? So from P, this is the tumor of the parotid gland. Okay, parotid gland. So this is benign tumor, and it involves the superficial lobes of the parotid gland, and it is slowly growing swelling over the angle of mandible for many years, and raised air lobule is present. It is painless, and facial nerve is not involved. Swelling cannot be moved over the zygomatic bone. If facial nerve was involved, then it would be painful, but the facial nerve is not involved, so this is a painless, and swelling cannot be moved over the zygomatic bone. So these are the clinical features. Now the differential diagnosis of the pleomorphic adenoma is parotid carcinoma, lipoma, lymphoma, cystic lesions, parotiditis, Sjogren syndrome. Okay, you should remember these, that it should be it can be parotid carcinoma, and it can be lipoma, it can be lymphoma, it can be cystic lesions, it can be parotiditis, or it can be Sjogren syndrome. If a swelling type of thing is present beneath the air, so first of all, things of the differentials, it may be parotiditis, that is the inflammation of the parotid gland. Then it can be the carcinoma of the parotid gland. Then it can be the lesions of the parotid gland. Then it can be the Sjogren syndrome. Then it can be the lymphoma, that is if any lymphoma develop here. It can be cystic lesions. Okay, now what are the things that are present in the Sjogren's syndrome? So, Sjogren disease is a long-term autoimmune disease that primarily affects the body's exocrine glands, particularly lacrimal and salivary glands. Common symptoms include dry mouth, dry eyes, and often. Okay, so here it is clear that Sjogren disease is a long-term autoimmune disease that primarily affects the body's exocrine glands. Okay, Sjogren syndrome is a disease of exocrine glands. So parotid gland is an exocrine gland. So this may be a Sjogren syndrome. Okay. So these 6 differential diagnoses you should remember that it may be parotiditis, it may be parotid carcinoma, it may be lesions, it may be Sjogren syndrome, or it may be parotiditis, or it may be cystic lesions, or it may be lymphoma or lipoma. Okay. Now, what are the management options for this case, that is pleomorphic adenoma? So, first of all, take the history of the patient, take proper history, whether it is firm or what is the duration, it is increasing or not, it is painless or not, what is the site and what is the age. Okay, is all the type of the carcinomas are related to these factors. For example, age. So the risk of carcinoma increase with age. For example, the site. So this pleomorphic adenoma are present at the site of below the ear or the lateral side of the neck. Pleomorphic adenomas are painless. It is firm and the duration is chronic duration, that is years, and it is increasing with time. So the following questions should be asking the history to confirm your diagnosis or to make your differential diagnosis. Now the investigation options are that first of all, fine needle aspiration is done, and it helps in differentiating the benign tumor from the malignant tumor. Okay, when you will take a fine needle biopsy, and you will do the biopsy, and it will differentiate whether it is benign or malignant. CT scan and MRI is done, which is done for the extent of the tumor. CT and MRI cannot give us diagnosis. It tells us about the extent of the tumor, that whether it is at T1 stage or N1 stage, or whether it is having metastasis or not. So the CT and MRI always show us the metastasis. Excisional biopsy is done when above ones don't indicate anything, and the treatment is superficial parotidectomy. As we have studied that the pleomorphic adenoma involves the superficial layers, so superficial parotidectomy is done. So what are the investigation options that we have studied? First of all, fine needle aspiration is done, and CT and MRI is done for metastasis, and you can do the biopsy, excisional biopsy, if the following investigation does not confirm or treatment. So okay, this was about the management options. Now, the structures which are at risk during the surgery of pleomorphic adenoma are facial nerve. Is facial nerve is present there. Retromandibular veins are present. External carotid artery is present. Maxillary artery, posterior auricular artery, and superficial temporal vessels. Now, this is a kind of tricky question, and it is important as well. And what are the structures that pass through this area? So these are the facial nerve, then the external carotid artery, and also the maxillary artery, as maxilla is present here. So the facial nerve, the maxillary artery, the external carotid artery, then the retromandibular vein, and the posterior auricular artery, and the superficial temporal vessels. These are the structures that are at risk during the surgery. So a side question can also be asked here. We have discussed the diagnosis, differential diagnosis, the management, the complications, the causes, the investigation, and the treatment. These are also we can mention this in the complications as well, that the injury of the facial artery, facial nerve, external carotid artery, maxillary artery, retromandibular vein, and superficial temporal vessels can occur in the surgery of the pleomorphic adenoma. Now coming towards the next topic, that is parotid carcinoma. Okay, so we have studied the inflammation of the parotid gland, then we have studied the adenoma of the parotid gland, which is slowly growing and painless and chronic history. Now we are going to study the differential parotid carcinoma. So the differential diagnosis are same, that is pleomorphic adenoma, acute parotiditis, malignant lymphoma, carcinoma, and for this case, we are having a scenario that is a 55-year-old male who is having the swelling on right side of the face. On examination, swelling in front of the right ear near angle of mandible, and swelling is warm, hot on palpation, and pain in the swelling is present. Okay. Right node of face on examination, swelling in front of right ear. Now in this case, we can see that there is a history of increased age. So the carcinoma is more in increased age, and swelling is present on the right face, swelling in front of right ear near the angle of mandible, and swelling is warm and hot on palpation, and pain is swelling in there is there. The investigations are same, that is fine needle aspiration, CT scan, MRI, chest X-ray, and excisional biopsy. The treatment options are radical peritodectomy with dissection of the nodes and conservation. Total peritodectomy with dissection of the nodes is done in conservative treatment. Okay, most of the times the nodes are involved in the parotid, so it is total peritodectomy with the dissection of nodes. Fraze syndrome and infection, trismus, cosmetic deformity, and seroma. These are the complications. Okay, these are a little bit of different things. That is infection and cosmetic deformity, seroma, and trismus. What is the Fraze syndrome? We will search Fraze syndrome. Okay, so Fraze syndrome is a rare neurological disorder resulting from damage to or near to the parotid glands responsible for making saliva, and from damage to the auriculotemporal nerve, often from surgery. The symptoms of Fraze syndrome are redness and sweating on the cheek area adjacent to the ear. Okay, so when Fraze syndrome occurs, it occurs when there is it is a neurological disorder, and there the parotid glands damage and the damage to the auriculotemporal nerve occur, due to which the flushing and redness and sweating of the redness of the cheek occur. Okay, so auriculotemporal nerve, Fraze syndrome. It is a neurological deficit, neurological, and auriculotemporal nerve is involved, as a result of which flushing and sweating of the face occur. So this was all about the parotid carcinoma. Now in the next section we are going to discuss the carcinoma of tongue and bronchial cyst, which is neck swelling, and then we are done with this unit of head and neck. Hello guys, welcome back. So now coming towards the carcinoma of tongue, we are having a scenario that there is 20 years old having ulcer on the lateral border of the tongue for 5 months, and he looks malignant on examination. No palpable lymph nodes. The diagnosis, the risk factors, the assessment of the conditions, the management, the lymphatic drainage and blood supply of the tongue, investigations, treatment, and role of surgery in cancer. Okay, so in this scenario, it is mentioned that there is a 20 years old and he is having ulcer on the lateral border of the tongue for 5 months. Okay, so look malignant on examination, and there is no palpable lymph nodes. So this is the carcinoma of tongue, and the causes or risk factors of carcinoma of tongue are tobacco smoking, pan chewing, and alcohol intake, erythroplakia, hyperplastic candidiasis, and ill-fitting denture. Okay, what are the causes or risk factors? These are tobacco smoking, pan chewing, alcohol intake, erythroplakia, hyperplastic candidiasis, and ill-fitting dentures. Now the clinical features for this condition, that is carcinoma or tongue, are that it is most common presentation is growth may ulcerated or bleed. Ulceration will be present on the tongue in case of carcinoma of the tongue, and cervical lymphadenopathy will be there, and there will be difficulty in swelling, and there will be unexplained tooth mobility, and there will be trismus, that is reduced opening of the jaws, and there will be restricted tongue mobility. Okay, so these are the clinical features. The most common presentation is growth may ulcerate or bleed, and cervical lymphadenopathy, difficulty in swelling, unexplained tooth mobility, trismus, and restricted tongue mobility. So first we diagnose the case by this clue that the ulceration is present on the tongue. Then the causes are tobacco smoking, pan chewing, and alcoholism, and hyperplastic candidiasis, erythroplakia, and ill-fitting denture, and alcohol intake. And the clinical features are that there will be growth may ulcerate or bleed, and cervical lymphadenopathy is present, difficulty in swallowing is there, and unexplained tooth mobility is there, and trismus, that is reduced opening of the jaws, is there, and restricted tongue mobility is there. These are the clinical features. Now the assessment of the patient. So for the assessment of the patient, history is taken. Okay, that is ask the patient about predisposing factors. Then ask if ulcer is painful or not, and it bleeds or not, and ask about a difficulty in mastication or swallowing. In case of the carcinoma of tongue or ulceration of tongue, there will be difficulty in swallowing, and there will be uh, problems in mastication, and bleeding will be present. uh, okay, now the examination of the oral cavity is done, and it is examined for the type of the ulcers and examined to exclude the metastatic signs. For example, if the ulceration is present on the tongue, then look if it is metastasized to the other oral regions or not. So this is the examination of the oral cavity. So while doing the assessment of the patient of carcinoma of tongue, first do the clinical examination and history taking. Then we will move towards the investigations, and fine needle aspiration is done, incisional biopsy is taken, MRI is taken, that is the investigation of choice for oral cancers. Okay, you should remember this, that for oral cancers the investigations of choice is MRI. And then X-ray is done, which is helpful for the assessment of bone invasions of the tumor, as tumor can invade the bones. So X-ray is done for that purpose, to find the bony invasions. Now the blood supply of the tongue is arterial supply, that is lingual artery, tonsillar branch of the facial artery, ascending pharyngeal artery, and vein. The supply by vein is lingual vein. Okay, so this was the blood supply of the tongue. Lymphatic drainage of the tongue. So the lymphatic drainage is to superior deep cervical lymph nodes, and to inferior deep cervical lymph nodes, and to submandibular lymph nodes, and to submental lymph nodes. These are the lymphatic drainage of the tongue: cervical lymph nodes and submandibular lymph nodes and submental. So the cervical are both deep cervical lymph nodes and superficial, superior and inferior cervical lymph nodes. Deep cervical lymph nodes and to inferior deep cervical lymph nodes, and to submental lymph nodes and to submandibular lymph nodes. These are the treatment options. Preliminary treatment. Preliminary treatment is scanning and polishing of the teeth is done to establish oral hygiene, and if necrotic or infective lesion is present, then oral cavity is washed out with hydrogen peroxide. And the definitive treatment is that surgery and radiotherapy are equally effective in the treatment of oral cancers. And if it is carcinoma in situ, then excisions of the lesions with 1 cm margin, about 0.5 cm deep, is done. And if lesion is less than 2 cm, then radiotherapy is done. If does not respond to radiotherapy, then surgical excision is done. And if the lesion is greater than 2 cm, then external beam radiation of lesions and lymph nodes, and excision of the lesion and lymph nodes is done. So this was about the carcinoma of tongue. We are having the clinical features of ulcers over the tongue for 5 months, and it looks malignant on examination. So the risk factors for the carcinoma of tongue are tobacco smoking, pan chewing, alcohol intake, erythroplakia, hyperplastic candidiasis, and ill-fitting denture. The clinical features which are most common is cervical lymphadenopathy, as it is tongue, so it is near to the cervix. So cervical lymphadenopathy will occur, and there will be difficulty in swallowing and difficulty in mastication, and there will be unexplained tooth mobility, and trismus may also present, and there will be restricted tongue mobility. Okay, these are very common features. Now for the assessment of the patient, first of all do the history, that is ask the patient about predisposing factors, that whether he is smoker or he is chewing pan or he is alcoholic, or erythroplakia, hyperplastic candidiasis, or any dental problems are present or not. Then ask if ulcer is painful or not, and the ulcer bleeds or not, and ask about the difficulty in mastication or swallowing. These are the points that should be asked in the patient, that is predisposing factors, and it is painful or not, it bleeds or not, and ask about the difficulty in mastication or swallowing. Then the another question is another step is that examine the oral cavity, examine for the type of ulcers, and examine to exclude the metastatic signs. The investigations are done, which are fine needle aspiration, incisional biopsy, and MRI, which is investigation of choice for oral cancers, and X-ray is done, which is helpful for the assessment of bony invasions of the tumor. The blood supply of the tongue is done. The blood supply of the tongue is arterial supply and venous supply. So the arteries that supply this tongue are lingual artery and tonsillar branch of the facial artery and ascending pharyngeal artery. lingual artery, tonsillar branch of the facial artery, and ascending pharyngeal artery. And the vein is lingual vein. Okay, lingual artery, tonsillar branch of the facial artery, and ascending pharyngeal artery. Now the lymphatic drainage of the tongue. There are three types of drainage present: cervical lymph nodes, submental lymph nodes, and submandibular lymph nodes. The cervical are then deep and superficial. Superior deep and superior deep and inferior deep cervical lymph nodes are the lymphatic drainage of the tongue, and two submandibular lymph nodes and submental lymph nodes are also present. The treatment options are preliminary treatment, which is scaling and polishing of the teeth, which is done to establish the oral hygiene. And if necrotic or infective lesion is present, oral cavity is washed out with hydrogen peroxide. And the definitive treatment is surgery and radiotherapy, which are equally effective in the treatment of oral cancers. Now, carcinoma in situ, the excision of lesions with 1 cm margin about 0.5 cm deep and lesions less than 2 cm is radiotherapy. If does not respond to radiotherapy, then surgical excision is done. Okay, treatment is providing according to the size of the lesions. So if it is carcinoma in situ, that is, it is not spread, then excision of the lesions with 1 cm margin about 0.5 cm deep, 0.5 to 1 cm. This up to this excision is done. If the lesion is less than 2 cm, and greater than 1 cm, then radiotherapy is done. And if does not respond to the radiotherapy, then surgical excision is done. If the lesion is greater than 2, then external beam irradiation of the lesions. Okay, for 2 cm radiotherapy. And if it does not respond to radiotherapy, then surgical excision. For lesion greater than 2 cm, external beam irradiation of lesions. And also excision is done. So the treatment is providing according to the size. The radiotherapy, the irradiation, and the excision, these are the choices of treatment. Now coming towards the topic, branchial cyst, which is also known as neck swelling. There is a young female who presented with painless swelling on the right side of the neck, and on examination, swelling is in posterior triangle of the tongue. Of the neck near supraclavicular artery with slight discharge of the pus. Young female presented with painless swelling on the right side of the neck. On examination, swelling is in a posterior triangle of the neck near supraclavicular artery with slight discharge of pus. Okay, this is a branchial cyst, and we have studied the parotid. It is present between the mandible and mastoid. Okay, and aspect of the neck, on the lateral aspect of the neck, just below the right ear. Okay, when it is about the parotid or pleomorphic adenoma, so the anatomical region will be between the mastoid and the mandible or near to the ear on the lateral aspect of the neck, while the neck mass, that is branchial cyst, will present specifically in the neck, and it will be in posterior triangle. So the swelling is mentioned in the scenario that the swelling is painless on the right side of the neck, and with slight discharge of pus. It is painless and discharge is present. So what is this? This is a branchial cyst. The differential diagnosis of branchial cyst are lymph nodes enlargement and hematoma, branchial cyst, pharyngeal diverticulum, and cystic hygroma. Okay, as pus is present there, so it may be hematoma, or it may be lymph nodes enlargement or lymph node swelling, or it may be branchial cyst, and it is pharyngeal diverticulum and cystic hygroma. Okay, so these are the differential diagnosis of branchial cyst. The investigations that are done are ultrasound, which is diagnostic, and fine needle aspiration, and sternomastoid contraction test. The treatment options are that excision of the cyst along with its entire epithelial lining is done, and one must ensure that the epithelial lining should be removed completely or else recurrence will occur. Okay, this is main point in the treatment, that the excision of the cyst along with its entire epithelial lining, and one must ensure that epithelial lining should be removed completely or less recurrence will occur. So this was all about the head and neck. So we have covered the orthopedics, we have covered the thyroid, we have covered the breast, and we have covered the head and neck. Okay. So in the next video we will discuss the we will also discuss the upper GIT in one session, and then lower GIT in the second session, and then urology in the third session, and also we will discuss the general surgery portion in two sessions. We have already discussed, I have uploaded the video, but we will revise it. So probably in 5 videos we will complete the revision. The general surgery portion I will upload it in 2 sessions, and the 3 sessions will be for upper GIT, lower GIT, and urology. Thanks for watching.